My name is Julia Leffler. I'm the co-founder and executive director of the MOG Project. I'm a MOG antibody disease patient myself, and I started this organization with others who had a real interest in bringing awareness to the disease and contributing to research, supporting other patients. And once we built it, we had everybody come globally to find us. And so, what we're trying to do here today is we're trying to provide education through these professionals that are here who run a clinical trial site. And we want everyone, if they're interested in the clinical trial, to know the entire experience and also what the clinical trial is about. So I have here with me our senior program manager, Sabrina Delafield. Sabrina, introduce yourself quickly.
Hi, everyone. Really excited to be with you. I joined the MOG project recently, and it's incredible to support the work that is happening across the globe. I have a background working at USAID, the UN, and different innovation and global health projects, and I'm very excited to be here. I'll pass it back to Julie, and I know we'll get going with the conversation and our incredible experts on the call.
Thank you. And I'm excited to I'll start with Dr. Ruth Geraldes. Is that how you pronounce your name?
That's very well.
Yes. Yes, please say hello and a little bit about yourself.
Hello, I'm Ruth Geraldes. I'm a consultant neurologist. I work in the highly specialized NMO service in Oxford as a deputy lead, where we see people with aquaporin 4, but also lots of people with MOGAD and some seronegative patients. I also lead the MS trials unit in Oxford, and I also have a background, and my background also of MS, and I do an MS clinic in a district hospital in Oxford. I work at Oxford University supporting some research around NMOSD and MOGAD.
Thank you. We also have Dr. Silvia Messina. Would you please introduce yourself quickly?
Hi, hello everyone. I'm Silvia Messina, and I'm a consultant neurologist, and I work in the MS clinical trial unit at Oxford University Hospital. And I'm also an investigator for the CosMOG clinical trials. And I have both clinical and research experience in managing patients with NMOSD, MOGAD, and MS. And I work closely with the highly specialized NMO service in Oxford to support in diagnosis, treatment follow-up, and then the research aspect.
Thank you so much. And of course, I hear such good things about Ana Cavey. She runs basically runs the clinical trial, makes everything go smoothly and interfaces with patients in a way that only she can. But Ana, could you please say hello?
Thank you, Julia. No, that's a very kind introduction. I'm just the bossy one that shouts at everybody and coordinates. So I've worked in the clinical trials unit for a long time. It was set up by Prof. Pallis, who I'm sure those of you from Oxford will know. And she's been an inspiring consultant to work with because of her knowledge between research and clinical practice. So I'm the nurse that coordinates the doctors and the nurses for running the clinical trials. And as you say, it's a real privilege to have that interaction between joining the healthcare professionals and patients together, and just making sure everything happens when it should happen. As anybody who's involved in clinical trials knows, we run very strict protocols. So being bossy is a huge advantage in that role. But again, thank you for allowing me to speak today and being part of this group.
Well, I'm sure that everyone does not think you're bossy, but sometimes that's what it takes. So we thank you for that. Let's see, what do I want to say here? I think we'd like to get started. Like I said, please, we have had a couple people join since we started. Please keep your mute button on unless you're talking. You can actually put your any kind of question that you have in the chat, or please raise your hand and we'll be looking for that. We'd like to have this be an interactive conversation, and we'd like to have you interface with the team here at Oxford and ask any questions that you might want to have about the trial here. And this is their perspective, and so we're trying to pass that off to you. Without further ado, I'd like to I'd like to turn, I guess, to Dr. Ruth. Would you be happy to talk a little bit about what you know about the clinical trial, CosMOG clinical trial, and what's going on at your facility?
Okay, thank you so much. So, as Julia has mentioned, this will be interactive, so feel free to interrupt me at any point if you don't understand what I'm saying. I just thought we should give a little introduction on MOGAD and why we need clinical trials in this disorder. As you know, it's quite a new disorder. So, until we found the antibodies not long ago, it was sort of mixed with MS and NMO. So now we know it's a totally different, separate disorder where we have specific antibodies that target myelin protein. And so it's a true autoimmune disease, contrary to MS that didn't tick the box for not a true autoimmune disease. So we have antibodies that target myelin, and this disorder affects the optic nerves, the spinal cord, and also the brain. And the presentations are slightly different in children compared to adults. We've had the antibodies probably less than 10 years, and we have learned about the disease course. And Oxford did contribute to understand and answer some of the important questions. For instance, we know some patients will relapse and others will not relapse. And we think that's around 50% of patients will relapse. And we know that with each relapse, there will be disability. Contrary to MS, we don't think there's disability accumulating in between relapses, but we do need to prevent relapses in people who are relapsing, because we know that visual acuity and visual loss will accumulate with each relapse, and the same with spinal cord involvement. In adults, visual impairment and optic neuritis are the most common. It's the most common presentation, but we do have, as I mentioned before, spinal cord involvement and brainstem and brain involvement too. The treatment of this disease has sort of mimicked what we did for NMO, which is a similar disorder where we have other antibodies, aquaporin 4 antibodies, but we now know that it's a different condition. It also associates with optic nerve involvement, spinal cord involvement, but the pathology and the mechanisms that have been elucidated in NMOSD with aquaporin 4 antibodies is very different from MOGAD disease. And I think we tended to use the strategies that we use for aquaporin 4, and we didn't have sort of a drug that was sort of specifically targeting the mechanisms of action in MOGAD. So we tended to use in people who relapsed so we don't treat usually with immunosuppressant patients who have a single attack. So we'll wait for the second attack. And if people have a second attack, then we will offer traditional immunosuppression. So azathioprine, mycophenolate would be the standard. Azathioprine preferred in women of childbearing age because mycophenolate would be contraindicated totally in pregnancy. And patients who fail these treatments, then they would be offered IVIG. And all of this evidence comes from case series from retrospective studies. So there was a lack of good evidence. So in clinical trials, we have different levels of evidence, and randomized controlled trials, we think, provide the best evidence to prove that a drug would work and is safe. So the CosMOG study is the second. So there are only two studies in the world looking at, or two randomized control studies. So this CosMOG study is one of them, is looking at anti-Fc receptor monoclonal antibody. And as you know, the antibodies have this Y shape, and the rozanolixizumab, which is the drug that we are looking at, will target these antibodies and sort of improve and the clearance of the antibodies, as if we have like for those who've had plasma exchange, where we'll filter the antibodies through an outside machine of your body. This is sort of an internal we can call it a plasma exchange, so trying to remove the antibodies from your body. So kind of looking at this more specific, and also it's sort of what happens when you give IVIG, sort of it also helps to take those antibodies. So the study is a placebo-controlled study. So this design was discussed with MOGAD patients, and it was thought, because there was no evidence, I know previous studies, that it was ethical to run a placebo-controlled trial. So everyone would start in 20 milligrams of prednisolone, and then people will be randomized either to the active arm with rozanolixizumab, we call it Rosie because it's a difficult name, for Rosie, and the others will be on placebo. And then within 2 weeks, everyone will go down to 0 of prednisolone. And those who are relapsing or might relapse, when if and they were on placebo, then will be allowed to go to the treatment arm, and so that is part of the study, that patients who are then having relapses and were on the placebo, they can go and move on to the actual trial drug. So this is a study for relapsing MOGAD. So patients who've had a single attack of MOGAD would not be eligible to be part of this study. And further, we would need patients who have had an attack, a relapse in the past year. So it's not any attack at any point. And then there's lots of things we need to check to see if people are eligible to be part of the study. Patients cannot be on any immunosuppressive treatment. So if they had previous attacks and they were on immunosuppression, we would have to wean them and stop the immunosuppression. And usually we have to increase the steroids a little bit before that, starting of the trial, so that we prevent relapses. And at least 3 months of immunosuppression to be included in the trial. Then we have lots of bloods. For instance, IgG needs to be within normal ranges, because Rosie might reduce a bit the levels of IgG. And there are other tick boxes that, if you have questions, then just to make sure that we are not including people with active infections, with active tumors and all of that. So the drug is a subcutaneous injection that's given in the subcutaneous tissue, and it's given every week. And the first part of the trial is a bit intensive, in the sense that patients would have to come in to be seen every week. And we've had wonderful, amazing patients who have committed to travel from very far to Oxford to have this treatment in Oxford. And then we will have home care. We have home care nurses that will be able to give the drugs at home. And then we will have 3 monthly visits. The visits, I will ask Anna to sort of talk a bit more about how these visits, and particularly the long visits, how do they look like? But we do lots of tests to look at different things, not only efficacy, but also looking particularly at safety, because we're doing trying to look at the new drug. When there are relapses, patients need to be seen within 72 hours with our team. So that means if they might be treated locally, but then we need to see patients locally and then confirm relapses. And the relapses, so we get all the information, and then we have to send information to an adjudicating committee who would say, okay, this is really a relapse. And then if we confirm a relapse, then we would act upon that. If the patient was on the placebo arm, it will go to the active arm. If the patient was on the active arm, then we may be able to offer other treatments. At any point, patients might say, I don't want to do this. I want to consider something else. And that's something we say to everyone who starts the trial, that at any point they can sort of say, I don't want to be on the trial, and then we can discuss other treatment options. I think, yes, I plan just to talk a little bit about the overall background, why we needed a trial, the trial design, major sort of indications and sort of contraindications for the trial. But then I think it would be better if we have questions for people to ask the questions. But I would ask Silvia and Anna to talk a little bit more of the practicalities. And today we are very fortunate to have patients who have been participating in the trial also here, and in different situations, and already had different experiences of the trial, and some of the experiences that I've just mentioned, having relapses, going back to so all of that can be shared with you, and I think that's sort of probably more informative than just me giving you lots of theoretical information. Julia, is that enough? Do you want me to go deeper or?
Hold on. Yeah, no, that was really, really fabulous. And I think that what we'll do is as things unfold in the conversation, I'd like anyone to interject at any time. No need to be polite here. I think we all are having a conversation. I think that'll benefit everybody here. I'd like to ask, before I welcome Allison, I'd like to ask Dr. Silvia and Anna, would you have any inputs to that, anything to add about the trial before we kind of move on to some targeted things?
Silvia, do you want to start or shall I say?
Just go ahead.
Okay. So when you're involved in a clinical trial, our priority is our participants' safety, and we measure the safety in lots of different ways. The most important one for me as a nurse is to get to know your patients or your participants. I'm not sure politically correct what we call you. Patient seems a bit rude, participant sounds a bit off, but basically the people we look after, we need to know them. They need to trust us because they need to tell us things. And we need to trust them that they're going to tell us things back. There's no point in hiding stuff from us. We want this drug to be seen as for what it is. So developing a relationship with your participants is really, really important to us. And then your safety, because of that, we measure it in lots of different ways. As I said, we know you. I'm terrible. I will know if people are telling me fat fibs, if they're having a bad day or a good day. But it's really, really important for us to know that. We measure your safety in lots of different ways. The most obvious one is we do a set of vital signs. We do your bloods. We do bloods for lots of different reasons, but the main one is looking at your healthy blood profile as is normal. Plus, we do lots and lots of antibody testing and things like that. Everybody groans when our nurse comes in with the tray with the blood tests on it because there's multiple tubes to be taken. We also do ECGs, which is a heart reading, just to make sure that your heart's happy and healthy. And then we divide the assessments into sort of the efficacy ones and the safety ones. So we have what we call a blinded nurse or a team that will come in and do some of the assessments. They know nothing about the trial. They don't look at the blood tests. We don't talk to them about side effects. And I always say, so imagine somebody being parachuted in and taking a snapshot of that patient on the day. So they'll do a neurological exam, and often ask them lots of quality of life questions. The quality of life questions are really important. No drug will get a license if it's successful from the EMEA, the FDA, or the MHRA. So that's the American, European, and English health boards, unless you've got quality of health data. The drug may be the most wonderful drug in the world, but if it makes everybody depressed or it doesn't help that sort of thing, they're not going to license it. So sometimes they are a bit burdensome, I have to say. They're endless. They ask you what seem to be some quite odd questions, but it's really, really important that we get those quality of life questions done. What other things do we do? I think that's about it. Questionnaires, assessments, and bloods, but everything is aimed at safety. Oh, one of the important things about the tests, especially the blood tests, is in a trial, we try and minimize bias and we try and do everything identically. If you come and see us in Oxford, if you're seen in China, if you're seen in America, on the visits that you come in, you will have the same assessments done. But also, it's the background thing. So all your bloods go off to a central lab. Now we have a European central lab, and I'm sure you have the same. Well, you do have the same in America. So we minimize the number of places that we use, and that can sometimes be a bit frustrating. If your bloods are a bit off and something's dropped a bit, normally we'd say, can we retest? Easy peasy, you go to your GP and have it done. In clinical trials, sadly, no, you have to come back to the centre, or we send a home care nurse out to do it, because those bloods have to go to the same labs. So the bloods that I take in Oxford are sent off to, I think we're using Icon. Again, the Accellacare, which is the home care nurses, they're sending it off to exactly the same lab. And it's those little foibles in clinical trials. If you want to know why we do things, there'll be a good reason for it, but ask, because it can be counterintuitive sometimes and a little confusing that we're so pernickety about certain things. So those and your MRI scans, for example, we review them in Oxford from a safety point of view to make sure there's nothing non-MOGAD going on as well as MOGAD things. But actually, from the trial point of view, they're all analysed in Canada, so they're whisked away anonymously over to Canada to be reviewed. So absolutely every test we do is reviewed. One really important thing is the anonymization. So, in fact, we're the only people that know our participants as who they are, as real people with real names. Um, Once we collect that data, it becomes anonymized. So you become a number. So there's no way that anybody can trace it back to you. And that's really, really important for people to know, I feel. And I think another question that often gets asked is, who do we tell that you're on the trial? And I know different health boards do it differently, but in England we tell the GP, and we also tell the clinical team that's looking after that patient. In Oxford, most of you are looked after by the clinical team, and we work very closely together, but some of you not so. But it's really important that the clinical team know what we're doing. Your clinical care comes before the trial. And we listen, we inform them of what we're doing and what's going on. And if there's any change in your condition, we obviously liaise very closely with them because we want the best for you. We want the best treatment that's out there. And sometimes we don't know, which is why we're doing the trials, but we will have that very open discussion with you all. And the third person we tell is your GP. GPs are amazing people, but they are inundated with information. We inform them that you're on the trial. If I'm really honest, they'll have no idea what the trial is about because they're not specialists in MOGAD disease. But we again provide them with pages and phone numbers so that they can call us and references on the internet so that they can call us if they're worried and again can liaise. And I have to say our GPs are fantastic. The most often question that we get asked is, you go in with something completely different. I'm going to pick something out of the air, a fungal nail infection. Can you have this medicine with this drug? GPs are really nervous about introducing new drugs without checking with us first, and that's brilliant. So again, there's a lot of open dialogue between us, your primary health care, and for us as well. I think that's about it, but please ask if there's anything else. And again, perhaps our two participants who have joined us can tell us whether that's what actually happens in clinic.
Yeah, I do have one more question before we go on to the patients, just to kind of open this conversation, and we'll get more on this later. But from any of the three of you, as a MOG antibody disease patient myself, there's a little bit of a fear that I think we all have about going into a trial simply because we don't know if we're going to be assigned a placebo or not. And the fear of relapse is really strong, especially with how devastating it can be. I know, I know what you're going to say ahead of time, but I'd love for you to talk to those people who are considering this a barrier into entering the trial. And also, there is sort of a misconception and please dispel this, that you could there at any time, you could assign that placebo to somebody. And so if there's any kind of bias and we have human bias in our own minds, but should anyone fear being looked at and saying, I think I'll give you the placebo. Could you please answer to
Okay,
that?
do you want to pick up this one and I can add if needed? Yeah.
Okay. So yeah, that's very, very good question. And this is what we usually, means the main discussion that we usually have when we are proposing or when we are discussing like a clinical trial with our participant. And I think that the most important message that we have to transmit is that safety is the most important thing, and like your safety is the most important point and aspect. So definitely we know that like in MOGAD, there is a risk of relapses and patients can relapse. And the important thing is that, of course, within the clinical trial, there will always be like a very prompt response, like patients will be seen very quickly, we will act very quickly. And if patients need like treatment, they will be treated with steroids. So the clinical aspect is always like the most important aspect. And we know also that in case of a relapse, the person can then switch towards the active arm of the trial. So then there will be like a moment where we know that the person is on the trial. And I want also just to clarify about the terminology, because like we were talking about placebo. So just to clarify for people who don't know what it is, placebo is the dummy drug, let's say. So it's like when we have to do a clinical trial, we always need like one arm of people that do have not be on the active drug. So because this is the way we understand if a drug is working. And then again, is a blind study. So it means we don't know that you are on which medication you are, and you don't know on which medication you are. And this is like the way we run a clinical trial to get like the best of evidence, as Ruth was saying before. And as I say, like if at any time you feel that you don't want to be in the trial for any reason, because you feel that it's like too stressful maybe to go ahead with the trial and to have this idea that you might relapse and you might be or not on the active medication, you can stop the trial at any point, like if you don't feel like you want to go ahead.
Can I just add that, so regarding the bias, so the randomization process is a very strict process. So no one will know. So we'll get patients when they are randomized. So when they come for the visit, the first visit, the baseline visit, we will put all the information in, and there will be an external entity that will allocate a number. And that number then will be allocated a treatment, and we have no idea whether the treatment is the actual drug or the placebo. So the whole team is blinded to that. So there's no way I could say, oh, you will go on to the treatment or you go onto the placebo. So this study designed for this, if you're using a good randomization strategy and blinding strategy, there's no way the team will know if they're being allocated to the placebo or to the actual arm. So there's no bias there because none of us will know that. And the reason why this study was developed and designed against placebo was because it was felt that the standard of care, so you can only run a trial against placebo when you don't have a good standard of care. And the fact is that the evidence for the current standard of care is not great. No, so it was felt that to be able to randomize against azathioprine or mycophenolate, you would need a much larger number of patients, and so you'd need the time. The design would have to be really difficult to be able to set up and to get the results. So I think the reason for that design was that it was felt that the standard of care was not good enough, and there was still some equipoise on whether you could actually. There are some patients with MOGAD, as you know, Julia, that even after the second attack, they don't want to go on immunosuppression, and we just follow them up. And if they have an attack, they will be promptly treated. We have several that like that. And if you know that if you treat promptly, the likelihood of recovering is very good. but it's always gets everyone very nervous, including the clinical team. So, instance, if you had a lot of disability and you're being randomized, and we don't know if you're on the actual drug or not, we will all be very vigilant. And I think maybe some of the patients might give you some of the experiences that we've had, but you know, in the future, if there's a good drug that we know that's been sort of totally effective in preventing relapses, we'll not be able to design trials against placebo. We would have to design the trials against the standard of care. I don't know if I've answered your two questions, but I hope I have regarding the bias and regarding the fear of the attacks. I think it's very fair, and it's also the team is also, you know, it's something that we are also concerned, and that's we insist. And I think all of our patients, they've heard me telling, you know there's a risk of relapse, there's so make sure that you're happy with this. So I think it's a totally natural fear. And I think we just need to manage that as best as we can, because this is the design that we have. And I think the design was discussed with patients, and I think it was felt that that was appropriate and we could sort of take that risk.
It was actually discussed with us. We helped to design the trial. And so I
Yes.
think that, our theory is, that is a risk, but if we, as long as somebody can be, we can get somebody on the phone. I mean, as a patient, the worst thing you want to do is have a real emergency on a Monday and have somebody at the front desk say, well, we can see you on Thursday. And that's just not the kind of
Usually
thing.
it's the Friday ones that we fear.
Friday ones. Exactly.
And just really quickly, from a practical point of view, so when you're part of the trial, and we're administering the drug, actually we have two teams of nurses that administer the drug. So they're very strict about the placebo and the blinding of it. So the placebo and the active drug apparently they're of a different viscosity. I can't say that word, viscosity, thickness. So when we're priming the lines to give it to the patients, and it's only a tiny job. So from putting the drug is in the syringe and then priming the line so that we insert it into the patient, it feels different. So we won't know which one is the real drug and which one isn't. But to prevent the nurses from having any bias whatsoever, a second blinded nurse actually just primes that line. And that's her only job in the trial. We don't talk to her about it or anything like that. I check the drug, we administer it, but that tiny little task, which could potentially, you would know that there's a difference between the two, we're not allowed to do that. So again, in the hospital, it tends to happen quite naturally. One of the nurses comes in, but it's very obvious when you're having the home care team in, because at the beginning, two nurses will come in, one to do that role and one not. And then once you go onto the open label, of course, we then know that you're on the real drug, so you only need one nurse. So that's sometimes why us nurses go around in pairs.
Well, that's great. Thank you so much. And I think with the time moving on, I'd love to have you introduce the patients that you brought today. Uh, I could do that, or one of you could please do that. I know they're your patients.
And I
I'd
do
love.
want to introduce Alison
Um,
and Anne-Marie.
Sorry, did you say me? I missed that.
Yeah,
But
well, so we have two wonderful,
yeah.
absolutely extraordinary participants in this study, and they've been sort of a joy to work with. So I don't know which one would like to go first, but I think Anne-Marie and Alison, they can sort of really give you a good insight of what's been the journey in the trial. So any could sort of start, I don't know, maybe Anne-Marie or
Well,
and then.
I would suggest you introduce yourself quickly and then just kind of give a story about, has happened to you very quickly with MOGAD, but how you got into the trial, what made you make the decision to enter the trial, and how was the whole process? And even if it was negative, we want to find out like what was done about it if something happens. So let's start with Anne Marie, since you're on my screen first.
Yeah. Okay. Hi, everybody. I had my first attack in 2021. And like everybody who gets it, it's a real surprise and real, it's quite frightening to begin with. But I managed well on steroids. And when my neurologist in my hometown wanted to wean me off of the prednisolone, I got down to about 3 milligrams, and I had a relapse. And I think possibly the relapse was triggered by having a knee operation a month previously. But anyway, I had a relapse. And then, so I was possibly going to go on to immunosuppressants, which I wasn't very keen on because I didn't like the idea of not being able to go out in the sun, and you've got to keep yourself covered up, and actually I like the sun and I like to get brown, and anyway, and then the trial was offered on email, and it interested me very much actually, because and then subsequently it certainly proved that by being part of it, I'm much more aware of what's going on. I actually feel much safer because I've got people looking out for me all the time. I only have, if I'm worried about anything, I only have to phone. And even if it's a weekend, I mean, I haven't done this at the weekend because it's not needed to, but I've got there's a pager number, so I can if I'm worried, I can ring the pager number. So I've always feel I've got contact with somebody, and the team, well, they're lovely. I mean, I enjoy my visits to Oxford every 3 months for the reviews or whatever it is they are. I've actually so I went on to the trial, and I don't know whether I was on a placebo or the drug itself. I hope it was a placebo because I had a relapse. In fact, yes, I had a relapse in June this year, I think it was. So I'm now on the drug, and nothing's changed. I feel just the same as I did before, but I feel I'm looked after. I've got someone there I can call on. Whereas when you've got something that you don't understand wrong with you, when you're I mean, I don't know what it's like in America, but to getting hold of people in your own hometown hospital and department, it's not the same. I've actually got contact with Oxford, and it's lovely. So I absolutely highly recommend it, and I feel fine.
That's wonderful to hear. And was there anything that you had that as you were kind of getting used to the trial was a problem that you maybe had to work with the team to solve? Anything from getting there to travel to
No, I understand I was the first one in this country to actually go on the trial. So the mistakes, well, not mistakes, but the things that weren't quite working, like for instance, getting the home care sorted out, that took a bit longer than it would, subsequently. But that was okay. I didn't mind. I quite enjoyed my visits up to Oxford. Unfortunately, it's a 3.5 hour journey, but it's not a difficult one. So no, I enjoy it. It's fine, and no, I've got nothing negative to say about it at all. Some of the online questions you have to answer, I find those tedious because they're difficult. They're difficult to it's difficult to sort of decide what actually applies to you. And when it's talking about health, are they talking about mental health, medical health, physical health? They can be a bit well. But that's the only negative thing I would say about it. But no, I think it's a wonderful program, and I'd like to carry on for as long as it's possible. I'm really happy doing it.
That's very great, and I'm so happy to hear that. That's a very good testimony about being in the trial. So, well,
just talking about the practical issues, obviously one of my jobs is to make sure that people can get to us, and the journey is easy. And actually, coming to hospital is always quite stressful. UK hospitals have car parks, but for the number of people that come in, driving yourself in and doing that can be quite stressful. So we have various ways of getting people into us and different ways. Some people choose to come under their own steam and provide their own transport, and we obviously reimburse their travel costs. Some people come in by train. Anne-Marie is amazing. She travels halfway across the UK to come and see us. We also, UCB, who are the sponsoring drug company, pay for or allow us to use their travel system, which I have to say is amazing. And we're using that one more and more. And basically, once patients have consented to give their details, because obviously they need to know where somebody lives, and they'll organise taxis and to get people in. Because when you're feeling well, coming in is fine. If you're having a relapse or you're scared and you're anxious, transport can be completely overwhelming, and we understand that. And just sorting those sorts of little practicalities is the reason, can be the difference between coming in or not coming into a study. And we try and make it as easy for you as possible. It's not always right, which is why we talk to each other, but there are different ways. And I have to say the sponsor has tried to make it as easy for us to make that happen.
Thank you for that. I think let's see if we can hear Alison.
Can you hear me now?
Yes.
Yes.
Well, I didn't have the microphone on. I play Fortnite with my grandson who lives in Cornwall, and unfortunately undone my microphone, so that's why I forgot. Okay, I'd like to thoroughly endorse everything that Anne-Marie said. Absolutely wonderful trial it is. As you said, the doctors and the nurses at Oxford are fantastic. You do feel like you're part of the family. They really look after you. I've been on this for a year now, just over a year. After my second relapse, it was very difficult to get my sight back. I had to have plasma exchange in the end. And this wonderful, wonderful, caring neurologists and nurses were absolutely fantastic. So when they asked me if I'd go on the trial, they gave me quite a lengthy document to read, which I did. And I've got 3 children. One of them said, "Go on it, Mum." The other one said, "Oh, what about the side effects?" And the other one said, "Send me the whole document. I want to read it." So we, as a family, we sort of got together and we decided that this was good. And if it can help other people, obviously, I'm over the moon. The home care has been wonderful. The nurses are fantastic. I'm friends with them now. They come to my house every week. Absolutely wonderful team. And Anna, especially at Oxford, is always in touch. If ever I need anything, I email her or the nurses. There's 2 wonderful nurses as well. And obviously, Silvia and Ruth are absolutely wonderful. Lovely, lovely way. And I'm so pleased I'm on it. I hope I'm on the drug, but hey, if I'm not, then I will be on it if I get a relapse. So nothing negative to say, all good. And thank you very much to a wonderful team.
Oh, thank you. And was there anything that you had to work out as you were entering the trial and getting there that you want to pass along to others, or anything that worked really well that you were really impressed about?
I'm impressed at the tests that you get, because obviously all the bloods that they take regularly and everything else, the ECG, you're getting a really good, MOT anyway, aren't you? For anything else that might be happening. So it's all good. There's nothing negative at all. I can't think of anything at all. There's been a few glitches, like Anne-Marie said at the beginning, with the home care team coming, and a courier has to come. The courier brings the medicine. If you're having bloods, a courier comes and takes. There's a lot of sort of bits and bobs that sometimes go wrong, but hey, it always happens on the same day, whether it's earlier or later. And usually it's over in 1.5 hours if it works well. So a very small price to pay, I think, just that Thursday that they come here. No, all good. I can't think of anything that would be negative. And also, if this helps, I mean, I'm 72 now, but if this helps people in the future, then I'm all for it, especially a lot of children who've got MOGAD. If this does help them in the future, then I'm all for it.
Yeah, I think that there's a community we're all sort of waiting to find out, certainly anecdotally, some of the ones we talk to are just doing well. They're happy with the trial as well.
Yeah.
I want you both to feel free to interject at any time in this conversation, but we have a question in the chat, and one of our guests has said she has a couple of questions. First one I can answer actually. She says, how can I get the recording to this session? Well, once we're done, I kind of clean it up, and like I said, if anybody who talked and was worried that maybe they showed up as a speaker on the recording and does not want to be seen, I can always edit you out and your question out. The email for me is you could always email info@mogproject.org, and Sabrina will put that in the chat. But we also have a YouTube channel, and on that YouTube channel, there will be these town hall meetings and recordings of them. And we will advertise the location of that. I think if Sabrina can find our YouTube channel and put that location in the chat, there will be, like I said, one for the CosMOG Town Hall meetings. There's already one there if you'd like to review that as well, that we did in the United States with Dr. Michael Levy from Harvard. And so here we are at Oxford today, and that will be up as well. So the second question was, if I would like to sign up to the trial, what is the process and what do I need to ask for my primary care? And this person is USA based, but I think that this is also applicable. How does somebody, if you just have no connection to a trial site, how do you get there? Like, what is there? I can also answer part of this too, but I'd like to
I
hear
can
from
speak in terms of the UK. We only have two sites. We have Oxford and we have Liverpool. So Liverpool will take people from the north and we will take everyone from the south. And because we run national services, most people with MOGAD should be reviewed at least once. But I think maybe some people will not, may not be coming to Oxford or to Liverpool. But if they have MOGAD, they've relapsed in the past year, they could potentially be eligible for the trial. It has to, and if they're not on an immunosuppression, that would make things easier because I believe the trial will end pretty soon. I think that the recruitment has gone well, and I think we are sort of almost getting to the limit of patients that will be allowed. And if patients are on immunosuppression, they would have to be off immunosuppression for 3 months, and then that would sort of might delay things. That's for the UK. I don't know, Julie, because this participant has mentioned that she's based in the US, and maybe you could give her some other information.
So Ruth and everybody else, the website that we refer anybody who wants to know about any clinical trial, there's a website called clinicaltrials.gov. So every clinical trial that is done in American, Europe and Australia has to register on that website. And within that website, because it's so big, you need to put in the disease group and the country that you're in, but then it will then list all the trials that are running. In that list, it's really helpful because it gives you the inclusion exclusion criteria. We haven't talked about those yet, but every clinical trial, the sponsor usually wants everybody's disease to be doing the same thing at the same time so that they've got some uniformity. And I don't mean to be rude about you as a group of patients, but you're minxes. None of you do that. But it's really, really helpful to see what the inclusion exclusion criteria is. Often we reject people, and we're not disputing your diagnosis. We're not saying anything like that. It's just that the sponsor wants a very narrow band of people with that disease, or that their disease doing a certain thing at that certain time. But the clinicaltrials.gov website is excellent because it lists the inclusion exclusion criteria. It also lists the centres that are available in all those countries. So if you go onto it, I'm sure that Sabrina can find the NCT number, and put the website up. But if you Google clinicaltrials.gov, put MOGAD disease in, and active trials, because it'll list all the ones that have happened, which obviously isn't very many, but there may be others related, and the current ones, and it'll give you the inclusion exclusion criteria and the centres that are involved in it.
Thank you, Anna. And I can actually add to that. We do have a page on our website, which I've put into the chat here. And the MOG project, we as patients will help connect you to somebody who can evaluate you for the clinical trial to see which site is best for you, to talk to you. And we have several in that clinicaltrials.gov link is on that website page, and there's an explanation very similar to what Anna said. Although Anna seemed to say it better, we should get her to write for our website. And there is also a CosMOG study website, and there's another organization that's connected to UCB called No Rare. And there's a form on on that website page if you want to fill it out. That'll come to us, and we'll contact you and try to help you find a clinical trial site. We'll keep up with you and just make sure you have any questions. We're patients too, and we want to help. There's a lot more in your question, which are all really good questions.
But I can answer a little bit of that if you want. So each patient is on a different trajectory. So if you're already on immunosuppressant, you'd have to have a screening visit in the beginning in the center. And of course, as I said, if people are already in immunosuppression, what we tend to do is to stop the immunosuppression and up the steroids a little bit more to make sure that there's no relapses until the baseline study. But that's sort of overall what we do. But it's not, each patient will be a different situation. And this trial only covers travel expenses. Patients are not paid to be part of the clinical trial. But travel expenses are covered, as Anna has mentioned before, or if people need to stay over, or anything that makes it easier for people to come in to the center, that is covered. I think I've answered those questions. I think for more specific details in terms of the transition, how you transition from your current treatment, because there are different treatments, I think that would have to be discussed with the local team who's doing the screening. Yeah.
Yeah, and that screening is very, very important. I will just give you anecdotally this patient that we know went from California to Boston, which, if you know, in the United States is almost as far as you can go. Really, there's further, of course, but just within the mainland. I think that that's a heroic move to be into the trial. It was early on when they were just opening sites, and he went and he stayed for a little bit. And UCB did pay for the flight. They also paid for his hotel and made the experience very comfortable for him. And I believe that they will continue to do that. That's not a one-off thing. Let's see, that answered all of her questions. Let's see, anybody have anything else that they would like to ask? Or you could raise your hand, or I'll give people a few minutes to think about it. I do want to kind of move on too, and I think that I want to bring up something that's always sort of the elephant in the room. When people talk about these kinds of things, I think there's a lot of people that feel that the trial's not right for them. We've already talked about the fear of placebo. I mean, that certainly is difficult, but there's this thought that maybe the whole point of this is that I'm treated like a guinea pig. I'm sort of just an experimental person in this thing, and what would you say to that? And yes, in some sense, obviously you're part of the trial. You are an important part, but there are benefits to the patient. And could you talk a little bit about that?
Yes, of course, I can start. And I think there was one of the participants here that said, you randomize and it's random and it's not for me. But I have to say that coming from the MS world, where 20 years ago there were no drugs available, and actually when a doctor was seeing a patient with MS and maybe with MOGAD or ACPON4, they were actually experimenting because they didn't know what was working on what was not working, because there was not enough evidence at the time. So okay, we'll try steroids. Okay, we'll try azathioprine, and I think it's much less. It's not as safe as being part of the trial. This is, of course, my opinion, in the sense that in the trial, you are trying to account for all the possibilities and to make sure that you're as safe as possible. And of course, it's particularly in disorders where you don't have a standard of care that has gone through the process of clinical trials before. So I think that the participation in the trial tends, as we've insisted several times, to be absolutely sure that we prove that the drug is working, and that we prove also that it's safe. And I think then this will allow clinicians in the future to have good evidence to make the appropriate decisions when they are in clinic with a single patient, because they will have all this group evidence that the drug works and from randomized controlled trials. I'm not sure if I've answered your question, but it's just that I'm just thinking, the guinea pig, situation for me sometimes happens more when you are sort of in a situation, you have a disease, you don't know what to do, and you don't have enough information from clinical trials or from other good evidence to support your decisions. Whereas in the clinical trial, you actually in a safe environment where you think, we're testing a drug, we don't know what that drug was, but we have all the support network to make sure that, if there's any problems, that will be picked up very quickly, and that's sort of minimized. For instance, in this particular trial, we know that IgG will go down, and we are very worried about infections. So we are always asking about infections. We are always looking at IgG. So we are always sort of making sure that everything is safe. But I agree with participants that it is a big commitment. And I think that for women and young people that are working and have childcare and all of that, that has been a problem. And I think we have to acknowledge this in this trial. Weekly visits is a big commitment. So I think it's not particularly in young and people who just don't have their bosses are not flexible enough to give them the time to come to travel, and so that has to be negotiated. So I think it is not easy to participate in a trial, and we are extremely grateful to everyone who has participating in trials for MS and for Aquapoint 4 and now for MOGAD, because that allowed us to have good evidence then people can then use in the future to make appropriate decisions and give the treatments that really work.
Thank you. That was very, very good answer. And another thought is that I think as a patient, we worry about maybe being pushed into a clinical trial, and I wouldn't want to be pushed into that clinical trial if it just wasn't right for me. Can you give us a couple of examples where or even guidelines as to the kind of person that maybe you wouldn't put into the clinical trial? In other words, were there people that you said, wow, I would recommend this for you, but I don't think this is for you. I don't think, even if they qualify, is there an example of that in your case?
Sylvia, do you want to say with some of our, or I'm happy to.
Yeah. No, I want to just briefly also adding to the previous discussion that I think one of the key points is also being informed, and in a way this links also with what we are discussing now about the ideal participant, let's say. So I think being informed and being aware of the benefit that you can get from the trial, but also all the uncertainty that we might have, that it's also related to the fact of the placebo treatment. And then of course, if I have a patient that is very aggressive, it's we have difficulty with controlling the treatment, in controlling the number of relapses, then of course I wouldn't even discuss this with the participant, or maybe we can discuss it, and again then we have to come up with a decision then together. I think that the shared information in between the physician and then the patients, I think is the key. So, or for example, if I know that the person cannot commit with like a weekly infusion, then it's something that I wouldn't suggest, of course. Otherwise, we can risk like lack of compliance, for example. And or if there are, of course, there are all the exclusion criteria that we go through that, like when we are screening or pre-screening, like a subject. And yeah, I think.
We had people, who were very keen to be
Yeah.
part, and actually, but for instance, some of the bloods were not quite right, and we tried, and we were waiting, and we did the bloods again and again, and at some point, we just said, no, we're not going to wait for the bloods to come up and to be normal. We just have to give you something else, and just forget about the trial. We're not going to wait anymore. So that was an example. And I guess, as Silvia was saying, patients who have, really sort of some of the contraindications for the trial, or they've had really sort of very anxious and very nervous about having another attack, or could not cope with that uncertainty. There's no one, even for the team, if you feel that that's sort of a big problem that would cause a lot of stress, we don't want people who are sort of not comfortable with the design. And as I said several times, and the thing that I would say to everyone when I'm screening, do you know there's a risk of relapse in this trial? Do you know there's a risk? Are you sure that you want to take? And I think if people are not comfortable with that, we would not at all insist on the trial. But the thing that people need to understand is that they go to something else, either IgG or IVIG or azathioprine, mycophenolate, and that the evidence for that is sort of, it's what it is. It's coming from case series, retrospective studies, so and people might still relapse on that. So it's not that, it's sort of the alternatives also have some difficulties, and so it's not that. And if that's why this trial was designed as it was, is because we didn't have like a super alternative. So I think that's, as long as everyone understands that, that's fine. We would never insist on someone going on to a treatment, but there are people who've tried mycophenolate, they've tried azathioprine, and some, the only option would be then IVIG, and they might have contraindications for that, and they might have severe headaches and severe so there wouldn't be also the ideal people for that. So then the trial is a good opportunity.
And I think once the doctors have talked to people about trials, and it's the nurses, we kick in, and actually I think the most important thing is, the question that I will always ask people is, does this trial feel right to you? Will it fit into your lifestyle? Is it the right trial? Do you want to go ahead with it? If your heart is not in a clinical trial, there's no way that we will ask you to be in it. You have to, it works both ways. We have to be committed, and it's really practical, and it's the practical issues that will actually lead people whether they want to do a trial or not. This is a lovely trial, but it's super heavy. Every 4 weeks. When you're not in the trial, 4 weeks sounds like forever. When you're in a trial, it whizzes round and comes round quite quickly. So again, it's asking, will it fit into your lifestyle? Is it the right one? Another a question that people often ask us is, being part of the trial, will it impact negatively or positively with the standard of care? And at the end of the trial, what's going to happen, and all of those sorts of things. So we're very open about what those sorts of things, what the implications mean. But I think a trial, it's so multifaceted about whether it's the right trial for you. There's the science behind it, there's the safety behind it, and it's how you feel about doing research and the practicalities of it, and coming to see us. I mean, I joked before about the car parking, but parking at the JR on a Tuesday morning, it's actually easier to do a NASA moon mission than it is to get to the JR sometimes. But those things are what makes a difference to people. We don't want to make your life more stressful, we're trying to make it less stressful.
And I think the relationship with the clinical team is really important, as Anna was saying. So, at any point, patients might say, I don't want this trial anymore, and I go back to the clinical team, and there has to be that sort of flexibility, and people need to be sort of, knowing that they can always go to the standard of care, and then that's quite important.
Wonderful. Thank you so much, everyone. This has been an incredible conversation. I know we're over time, but just before we jump off, we wanted to invite Allison and Anne, if there's anything else you would like to share about your experience with us before we sign off for the day.
Well, anybody that's in doubt, as far as I'm concerned, if they've got the time and they're retired, of course, which I am, go for it, because I think it's a wonderful experience and you feel well looked after. I don't think you're going to feel as well looked after if you're just on a drug and having your yearly visits or whatever it is. I think it's a wonderful experience and I'd do it again.
I completely agree with you, Marie. I can't see that there are no negatives for me. I'm being looked after by a wonderful team. Whether I'm on the placebo or the drug, I know I'm being cared for regularly. And even if I have a relapse, then, I've got all the contacts there. So it's a win-win for me.
I've just noticed that we have Leonie also with us. So, and she has her hand up. So she's one of another of our patients. So sorry, I couldn't see anyone, and now I can see the hand up.
Oh, I don't see.
Hi, sorry.
Jump in.
Yeah, I just wanted to say that I work and I've been very fortunate in being allowed to have the time off for the visits. But actually now the home care team are actually happy to come to my place of work to do the infusions every week for me. So that's something else that's going to be, really helpful. I mean, I don't have to take so much time off. So even if you are working, yes, at the beginning, it does take a big time commitment, but over time, that can potentially ease off as well. So yeah, I just wanted to say that.
Well, thank you, and thank you for joining us. I think all the patients here should get together in October for our Mogmates Day, that we ask people to connect with each other and go to a restaurant, go get coffee, go bowling, skydive, whatever you want to do together.
I died while in the trial. Just you have to discuss this with us first.
Yeah, find a way to connect. But we do have a UK Facebook group. We also have a Mogmates Facebook group, so look out for that. So I want to thank everybody. This has been a wonderful conversation. We got out of it exactly what we wanted to. We got some great questions. We got a lot of information, and while there's a number of people on here, some of who are in the trial, some who are definitely interested in the trial, this resource will go on our website and actually on our YouTube channel and the website. For people, it'll be a lasting resource. So everything that was said here will help so many. Some people just couldn't make it today, and I know everybody's going to go off and enjoy their holidays, and it's a busy time of year. So I certainly appreciate everybody coming here and taking time out of this busy time. I know you all want to get off and go shopping, so or make preparations. So I hope everybody enjoys their holiday season, and thank you again. We'll sign up.
Thank you.
Thank you. Bye.
Thanks, everyone. It's been amazing to be part of this, and thanks everyone, particularly the patients. I'm very grateful for everyone.
Very, very grateful. Thank you. Take care, everybody.
Thanks, Julia, for organizing this. Have a good weekend. Bye-bye.
Thank you.
Thank you, everyone.